right now. This is a good thing. This is more like extra info. Nothing that you really have to focus on too much. But essentially, in norepi, we have this big floppy tail that can rotate around like a pinwheel. And so it goes around, 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 around. And it means that the drug has a hard time. It phenylethylamine based drugs can have a harder time getting into the right configuration. Compare this to clonidine, which has this weird property to it where the imidazoline ring is always perpendicular to the phenyl ring. And what this does is it puts the nitrogen in the correct format, enabling 100% the correct fit, where you wouldn't necessarily get that with norepi 100% of the time. So what do you have to know for this exam? Essentially is that when you look at the overlap between phenylethylamine, I saw a really good picture today. When you look at how they overlap, oh, I wish I saved that photo. It's such a good photo. Essentially what it is that the nitrogens that are inside of clonidine actually overlap with where the oxygen and the nitrogen are in norepinephrine. So that's why the imidazoline ring also works as a backbone for the phenylethylamine, is because they actually overlap very, very consistently, if that makes sense. I'll see if I can, well, I've given you guys some practice. I'll see if I can find that picture because it was very, very, very good. It like clearly showed it. Maybe I'll just remake it myself. But all right, let us dive into Thera. Exam 2. Smoking cessation, one of my favorite lectures of all time. But first, we are going to start with urinary incontinence. One of the fundamental characteristic of urinary incontinence is the idea that, how to phrase this, is the idea that is, yes, I can do that for structures. Yep. The main characteristic of urinary incontinence when we talk about it is involuntary leakage of urine. And this is a really, really important idea to get across because the control of urine is partially controlled by smooth muscle, meaning it's part of the autonomic system. But we also have the ability to control the emptying of our bladder directly and consciously, which means that evolutionarily, the ability for the body to take over urination or the conscious mind to take over urination is very, very important. Not only can we cause urine to start to flow, but we can actually speed up or slow down the force of urination by squeezing the pelvic floor. Because of that, what we essentially have is a very, very complex disease, mostly because we have lots of different etiologies, or in other words, causes of urinary incontinence. So with that in mind, let's jump in and let's talk about the major types. And I am just going to grab a very nice picture for us. Don't feel like you have to copy this picture down, but I think it is helpful to have something to reference. When we talk about urination, what we are focused on is the interaction between the internal sphincter, the detrusor muscle, which, as we know, goes all the way around, and also the pelvic floor, which is can I get a good picture of the pelvic floor? I'll just add it onto this one. The pelvic floor is the muscle that all of this sits upon. And depending on where you have your dysfunction in your physiology, we get different kinds of urinary incontinence. Overall, what we have is three major types. The first is stress incontinence. The second is urge incontinence. And the third is overflow. If there's one thing you take away from this session tonight, is the definitions of these different kinds of incontinence. Stress is due to an increase in abdominal pressure. Urge is detrusor muscle contraction. And overflow is what would I say? Impaired detrusor contraction or a blockage. Sometimes they split apart the blockage into its own separate category of things, but where I usually put it is with overflow. We'll talk about other characteristics, like I think she talks about functional incontinence and mixed, different stuff like that. But really, these are the three major things. Stress incontinence has to do with the pelvic floor. Urge incontinence is focused mostly on the detrusor muscle. And overflow is focused on not only the detrusor muscle, but also the sphincter themselves. So we could also put that in there. Impaired detrusor contraction, but also detrusor and sphincter contraction. All right. Let's start with the first one, urge incontinence. Stress incontinence. Forget the order. When we look at the pathophysiology of stress incontinence, there are three major causes. The first is that we have urethral hypermobility. Which is really just a fun way of saying is that in women, they in women, it's a failure of the urethra to hold back urine due to pressure. So you know when you have a really, really bad urge to pee and you clench and you clench and you clench and you clench, and that prevents the bladder, no matter how hard it tries to push, from being able to pee? Well, especially in women, the ability to clench the urethra is minimized because the length of the urethra is smaller, as well as the number of muscles that surrounds the urethra is smaller. What ends up happening here is that things like childbirth weaken the muscles around the urethra, making it less able to resist high pressures. The way to think about this is that it's almost like if I punched you in the stomach, no matter how hard I punched you, your urethra would not be able to hold back all the urine. But what happens if I just touched your stomach? Well, someone with hypermobility within the urethra would not be able to resist even that small increase of urine in pressure because the urethral muscles are weakened. The second way this really happens is intrinsic sphincter weakening. So instead of focusing purely on the urethra, we can look at the different sphincters that are along the pathway of urine being removed from the body. And what we see is that in cases of advanced age, obesity, or surgery, the innervation and the ability to close sphincters to prevent urine outflow is impaired. So not as good as when you were younger, is that the sphincters become weaker. And then the last way that stress incontinence is caused is by a sharp increase in abdominal pressure. This is things like sneezing, coughing, laughter, if someone punched you in the stomach. And what is happening here is that the pushing of the peritoneum on the bladder is forcing pressure downwards and pushing urine through the sphincters. When you think stress incontinence, what I want you to think is gravity pulling the urine. So whether that's because the urethra cannot clench or sphincters cannot clench, or there's increased pressure, gravity is dragging the urine out of you and you're not able to resist it. I should also mention here that postmenopausal women often have this issue due to a decrease in urine, decrease in estrogen, not decrease in urine. One of the big things that we do in order to diagnose urge incontinence is what's called the bladder stress test. And essentially what they're going to have you do is you stand, and then they have you cough repeatedly, or they have you laugh repeatedly, or sneeze, or do something like that. And they're a positive test during one of those activities is indicative of stress incontinence. If you're able to cough and you don't have urinary leakage, then it's probably not stress incontinence. Mm-mm. Now, when we talk about the treatment of stress incontinence is due to mostly um, uh, unchangeable conditions. What this means is that what we are trying to do is preservation and conservation. So, in other words, you're not going to really have many drugs that are going to work well for stress incontinence. The reason for that is because of natural weakening of muscles that are already there, or you have sharp increases in pressure. And it's very hard to give someone drug saying you will never laugh again with this drug, or you are going to never be able to cough, which, not great if they have something stuck in their throat. So what that means is that we're focusing on rebuilding muscle tone. This is things like Kegel exercises, which are often given to postmenopausal women or women after childbirth. And this is all about strengthening the pelvic floor. You also have activities that are going to help decrease uh, the pressure built on the bladder. And this is mostly losing belly fat. The idea that when you have gut fat, that is pressure on the bladder is one of the biggest uh, lifestyle changes that can be made. Likewise, avoiding uh, diuretic foods. So things like alcohol, nicotine, which is going to decrease the tone, caffeine. So we're decreasing the pressure, not in the sense of like physical pressure, but in the sense that the bladder is having reduced action, is the way that I would put that. Can I add more space? Nope. I can get a little bit more space. That's all I need. Treatment is TX is treatment. Yep. One of the things you'll also see used is what's called a vaginal pessary. What is, I don't like the way that looks. We'll just have to go back up. A vaginal pessary, which is an insert into the vagina that helps support the organs around it. So it's like a silicone or latex device that is rigid to help with supporting the abdominal organs. And then finally, most importantly for us, there are a few drugs that we can use, although in very limited circumstances. For this, we're really focusing on the sphincter tone. So we are really the not so much maybe not sphincter tone. It's actually the detrusor contractility. And what we're going to be using is anticholinergics. Oxybutynin, sometimes atropine, although not very often. And these muscarinic antagonists are going to be working on, of course, the M135 receptors and decreasing the contractility of the detrusor muscle. What's important to note is that you can only use this in mild stress incontinence. If you have very, very bad stress incontinence, meaning that a cough makes you leak a large amount of urine, or if you cough and you cannot eventually stop the flow of urine before your bladder just fully empties, then really the only way that we can fix this is with surgery. So the what's called a mid-urethral sling, which elevates the urethra and it essentially puts like a U-bend in the urethra. So what should you know about the treatment for stress incontinence is essentially lifestyle modifications. So cutting out foods that cause diuresis, alcohol, caffeine, nicotine, and increasing muscle tone. So Kegel exercises, anything that's going to help the pelvic floor. And very, very rarely are we going to use anticholinergics. Any questions about that? Welcome home. All right, let's move on to urge incontinence. Is this making more sense than class as well, by the way? Am I giving you guys more info than you need to know? Okay. All right. Urge incontinence. Essentially, what we have going on is two possible causes. So we can either have a neurogenic disorder, which it means that it originates in the CNS, or we can have inflammatory conditions, which in terms of urge incontinence, we're talking about UTIs, especially in men. Either one of these causes is going to cause one of three things. The first thing is that you have sphincter dysfunction. You have detrusor overactivity, which is essentially that it's over flexing. So instead of pushing a little bit of urine out, it pushes a huge amount out. And overactive bladder, which means that both the sphincter and the detrusor are acting up. So overactive bladder is the combination of both. You have a sphincter dysfunction and detrusor overactivity, leading to an overactive bladder. And the result is autonomic or autonomous contraction of the detrusor plus relaxation and plus premature micturition reflex, which encompasses a lot of the smooth muscle and the sphincters surrounding the urethra and the bladder. And remember that micturition is the fancy medical term for peeing. So essentially, you have some sort of CNS disorder or inflammatory conditions, such as due to UTI, which causes a dysfunction either in the sphincter, the detrusor muscle, or both, which then leads to the body overactivating the peeing reflex. So your body is like, oh my God, I gotta pee. I gotta pee right now. My God, I gotta go pee. What's important to note is that because of this pathology, you have strong, sudden urges to pee. The reason why it's called urge incontinence is because you have urgency to find the bathroom. Unlike stress incontinence, which is involuntary leaking, right? You're coughing and a little pee comes out. Urge incontinence, you are fully aware that your body is getting ready to pee. You have a conscious knowledge that your body is like, oh my God, I'm going to pee myself. I got to go find a bathroom. And the reason why incontinence happens is because you cannot hold it. Your body overcomes the conscious inhibition of urination, leading to the incontinence. Does that make sense? Any questions about that? Okay. Because of this, this means that the treatment for urge incontinence is much more drug oriented than stress incontinence. So if you had to choose between treating stress incontinence or urge incontinence with drugs, urge incontinence is always the right answer. Driven by drugs. So while stress is really driven by lifestyle changes and exercises, urge incontinence is driven by drugs. All right. As pharmacists, we should always be prepared to have non-pharmacological interventions. And once again, this includes things like exercises, diet changes, so reducing alcohol, reducing caffeine, stuff like that. Also, behavioral therapy can be very useful here. Do you ever have the urge to pee as soon as you get home? Like, remember when you were in high school and you would get home, the first thing you need to go was go pee? That behavioral reflex of walking into a place that feels safe and feeling the urge to pee can be modified with behaviors, with like a cognitive behavioral therapy. It's very, very interesting how it happens. In terms of drugs, farm first line are anticholinergics. Why are we using anticholinergics first line if they have so many side effects? The reason is because they're going to be they are going to reduce parasympathetic output from the CMS. So remember, this is all about the body causing the urge to pee. That's all controlled by the parasympathetic nervous system back in the brain. So using drugs that are going to specifically work on decreasing parasympathetic output are going to decrease detrusor activity, which is going to reduce voiding. Yes, exercise will always be a great way of helping, because strengthening, what happens over time is that as people are clenching so much in order to resist urine from leaking out, they actually weaken the muscles in the pelvic floor, in the urethra, around the bladder. And so you need to be able to build that tone back up. Essentially, they get tired. So exercises are always a good non-pharmacological intervention. Of course, anticholinergics, which, by the way, don't forget, these are the same thing as antimuscarinics. They are the same word. They are have lots and lots and lots of side effects. Dry mouth, the potential for glaucoma, constipation, as you've gone through in peak hole. So they do the job. They do a really, really good job, but they have their side effects. In general, when we look at the drugs here, and if there is one drug that you should think of, is oxybutynin. For whatever reason, oxybutynin has a particular benefit in the detrusor muscle. And when you think of any kind of antimuscarinic for incontinence, think oxybutynin. After oxybutynin, you get tolterodine, and I would say trospium is the other one. The extended release formulation is preferred over immediate release because of decreased side effects. Exactly. Systemic because it needs to go to the bladder. Yep. So ER, extended release formulations, are always going to be preferred over immediate release, purely because you can decrease the the extent of the side effects at a given time. I also believe that oxybutynin comes in a transdermal patch. So you place it right over the bladder, so you get less systemic effects. The other thing that we have are the phenicins. So dariphenicin and solifenicin, which are selective M3 antagonists. What we find is that M3 is highly distributed throughout the detrusor muscle. And so having drugs that primarily go to M3 means that they have higher benefit in the in incontinence. The only thing for this is that they have more constipation. And so in older adults, so more constipation than other anticholinergics. So the only thing I would caution is that in older adults, may not be the best choice. And who can tell me why, even though these guys are selective M3 antagonists, so they're going right to the detrusor muscle, why would we maybe want to avoid the dariphenicin and solifenicin in older adults? They actually have the opposite. Most elderly individuals have, right. Remember that as you get older, your innervation, your parasympathetic innervation goes down. So your ability to move your bowels decreases. You're eating a lot less, which means that you have a lot less fiber. And generally, older people are drinking a lot less water as well, which all combines that older adults are usually very, very constipated. And so giving these drugs means that you can make them extremely constipated. So one of the backups that we should always think about giving with anticholinergics is diarrhea, like Miralax or Docusate, all those good ones. Stool softeners, 100%. Second line, we have the beta 3 agonist, mirabegron. It's a newer agent. It's newer. I think it's more expensive. It does the job. You know, it 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 does its thing. But in any regard, remember that what this drug is going to do is it's going to cause relaxation of the detrusor muscle. What this is going to result in is more urine storage. Now, even though mirabegron is a beta 3 agonist, it's still going to have some activity at the other receptors, especially beta 1. So we get things like hypertension, tachycardia. You also see an unfortunate side effect of causing UTIs. So if you relax the bladder, that means that you get more urine storage, which enables bacteria to move up the urethra. So peeing less can result in UTIs, which is why, women are often told that once you have sex, you should go to the bathroom. It's the same thing, same concept here, is that if you pee less, you have an increased chance of side effects. The benefit of mirabegron over the anticholinergics is that these side effects are much, much, much less. Way more, you're going to get tons and tons of benefit with very minimal side effects with mirabegron. The issue is that it's new, it's expensive. If I look at GoodRx, I wonder what it shows up as right now. Because it's more selective. Exactly. Yep. So same thing. If you use darafenicin or solifenacin, you'd have a better profile than if you used oxybutynin, for example. But you do have to worry about that constipation. Let's see. How much is... Yeah. So you can see that in order to get Myrbetriq, which is is the brand name. It's only available as brand right now. To get per month about $400, no matter where you go. So you can pay $400 a month to not pee yourself. Not great, right? The the thing that and of course the last line option is surgery. Surgery is always the last line option for any incontinence. So if you use the drugs and still not working, go to surgery. Bear in mind that the choice of drug is very dependent on what kind of patient you have. Even though the anticholinergics are working more on the parasympathetic nervous system, they come with their own host of contraindications, right? You wouldn't want to use these drugs in someone who has glaucoma, for example, or severe constipation, right? So not great. But we can overcome a lot of those side effects by giving an ER formulation. So higher dose extended over a longer period of time. Any questions about that? Bit unrelated. Is this about as much detail as she went into in class, or am I going like way overboard? Okay. I just want to, I don't need to overteach for this, right? I'm not giving you the exam, they are. Go back to treatment real quick. To stress incontinence. Rebuilding muscle tone, decrease pressure. Okay. No problem. All right, let's go into the last one, which is overflow incontinence. Overflow incontinence, as I said earlier, is essentially the idea that you have chronic retention which leads to the like spilling over of urine. So imagine if you were filling up a cup, and you kept filling it up right until it got to the top. That is you when you are so full of pee that you just can't stand it anymore. So imagine that's you all the time, and then you make a little bit more pee, and that comes out. But you can't ever get rid of the pee that's inside of you. So you always feel like you have a full bladder. That's what overflow incontinence is you have chronic retention causing you to have this really, really full bladder all the time. And then the incontinence portion is that you have this spilling over of urine that you can't control. This is different than urge incontinence, which you can still control. If you want to go to the bathroom, you can let out all the urine you want. Whereas an overflow, you have some sort of pathology that's preventing you from releasing your urine consciously. Does that make sense? Does anybody have questions about that? It's a good question. Does this have to do with the size of the bladder? In a way, yes. You can think about this situation happening to you if like you and a bunch of friends were on a road trip and you couldn't pull over to urinate. Then, people with smaller bladders would become incontinent first. But really what the issue here is the inability to contract the detrusor muscle. Remember that the detrusor muscle is responsible for pushing the urine out of the body. And so if you have something like a spinal cord injury, which innervates the detrusor muscle, or often we see this with things like multiple sclerosis, advanced MS. This means that your ability to consciously or unconsciously contract the detrusor muscle to let out the urine is impaired. This can also be caused by drugs. What kind of drugs would cause you to have an inability to release your urine? What drugs would cause an inability to release your urine? Cholinergic or anticholinergic? Post-op drugs? It's a good guess. It would be our good old friends, the anticholinergics, right? So, in a way, urge incontinence is when the body is pushing urine out. Too much detrusor muscle action. The other extreme end to that is overflow incontinence, where you cannot get rid of the urine. And so anticholinergics can cause you to just retain urine so much that it leaks out when you don't want it to. Often, this is not because you are giving an anticholinergic. If this situation happened, we would just stop giving you whatever was there. But it's drugs that have a main action somewhere else in the body, but activate or have anticholinergic action. The kind of quintessential one here is Haldol, which is haloperidol, which is also the name of my gray bird. And Haldol is a very, very potent antipsychotic. So Haldol is specifically working on dopamine receptors. That's why we use it for the body, but it also is a very strong anticholinergic, which means that one of the side effects that can happen is retention of urine so much that you develop overflow incontinence. Does that make sense? Any questions about that? By the way, the reason why my bird is called Haldol is because he's super chill, and that's what Haldol makes you feel like. The other way that you can get overflow incontinence, right? Chronic retention, is that instead of reducing the pushing, you block the outlet. And this is where you have some sort of obstruction. The obstruction can usually be due to really only a couple of things, but you're either going to have some sort of bladder stone, you are going to have what's called a urethral stricture, or for men, benign prostatic hyperplasia, BPH. Why is Bactrim? Because what was it that he did? What was it? Oh, he's the color of the tablets. Good question. Urethral stricture. This is essentially where the diameter of the urethra is constricted. So this could be because of like inflammation. So you have some sort of infection or trauma around the urethra that's essentially swelling it shut. It could be because of a catheter that got clogged, or more often it's really inflammation or trauma that's causing it. So it's almost like you when you have a hose and you like bend it to cut off the flow. That's essentially what's going on. All right, BPH. Let us talk about let's finish off overflow incontinence real quick, and we'll dive into BPH, and we'll be able to finish this up. Is this making more sense in class, by the way? Okay, great. She didn't even talk about them. All right, perfect. Was she like part of a double lecture? Like, did she get the second half of the day? Is that why? Oh, it was a 15-minute class. Okay. All right. For treatment of overflow incontinence, we're focusing mostly on how either there was some sort of event that happened that's causing the issue, or we're waiting for surgery. So what do I mean by an event? I mean more like you got into a car accident and you had spinal cord compression. In that case, what we're essentially doing is waiting for the spine to repair itself. Or maybe you're in the middle of a multiple sclerosis flare up. And so as we're waiting for your MS drugs to kick in, we're going to use these tools. These short-term options are generally, what's the way of putting it? They're good for months to years, but they're not going to solve the situation, I guess is the way to put it. So these are a treatment, not a cure. Does that make sense? It's a very, very fine distinction. The first way that we can solve this issue is with what's called intermittent catheterization. Essentially what this is that you have scheduled bladder emptying session using a catheter. So maybe every 4 hours, a nurse comes in and inserts a catheter into a patient to allow the urine to come out. This is especially useful in people who had trauma, like a car accident, because in this case, they have limited mobility to get them to them, like to perform the catheterization themselves if they can do that. But it's one of the most favored short-term procedures because we can essentially, if it's possible, do an indwelling catheter. An indwelling catheter is essentially where we're just going to leave the catheter in the person throughout the day. And this would be hooked up to a bag, enabling for urine to be released as soon as it's produced. The drawback, and I'm putting adverse drug reaction, but it's not a drug, is that you have an increased chance of UTIs. So, and remember, UTIs are also a cause of incontinence, right? But a different kind. So also not to mention that it, you can cause a systemic infection and then you have a big, big issue. The next short-term option are alpha-1 antagonists. So think doxazosin, prazosin, terazosin. And what these are focusing on is decreasing the size of the prostate to enable to decrease urethral compression. And if you're wondering what the fuck that means, don't worry, we're going to talk about it very, very shortly. But I just want to put it in here because it's pertinent to what we're talking about right now. So we're using the alpha-1 antagonists purely on this obstruction issue, right? Obviously, if you have bladder stones, we need to pass the bladder stones. If you have a urethral stricture, we're going to solve the stricture, but BPH is specifically going to be treated by the alpha-1. In terms of the detrusor muscle contraction, what drugs should we use to solve this inability to contract detrusor muscles? What should we use instead? Cholinergics. Exactly. So we're going to be using our muscarinic agonists. And so what these are going to do is increase detrusor contraction and allow urine or bladder emptying. What's the question mark for, Pierre? Oh, for the cholinergics. Yes. All right. Long term are solutions where we're going to essentially remove what the issue is, right? So if you have in a way, what we're looking for is a cure. And so we're looking for things like um, prostate surgery, or sometimes they'll do urethral dilation. So they put a tube inside of the urethra in order to keep it open and bypass the stricture. Now, obviously, these long-term solutions are very dependent on what is causing the issue, right? If you have a spinal cord injury that is not going to that's not going to recover on its own, obviously, we're going to have to rely on the catheterization and maybe muscarinic agonists. But these long-term solutions are looking more towards a cure rather than just treating the symptoms. Any questions here? All right. Who likes charts? I know you all like charts. Who would like a chart?
Me.
Me. Here's a chart. Um, if you're handwriting this, please just take a picture. I'm going to move on from this very quickly. It'll be in the recording, obviously. But this just summarizes the different drugs that we're using and all that good stuff. Oh, I didn't mention tamsulosin. Tamsulosin's a good one. Silodosin, different stuff like that. Also, here's a very good picture to put in your notes. Oops. Boop. Here's a picture. So again, if you're handwriting, just take a picture for now. And obviously it will be in the recording. But any questions about incontinence before we dive into BPH? I know, what a good chart, right? What a good picture. Shows everything. All right. Let's talk about BPH. Benign prostatic hyperplasia. And then we'll come back to urinary incontinence. The oops. Why? There it is. BPH is a condition that affects the prostate of males, in which the enlargement of the prostate creates a stricture around the urethra. So what does that all mean? If we look at the anatomy of the body, in males, they have the bladder up above, and surrounding the bladder, kind of like a donut, is the prostate. The prostate is it's the best way of explaining it. How do we explain the prostate? You guys took anatomy, right? You kind of know about the prostate, but whatever. I'll talk about it. The prostate is a accessory gland located just below the bladder. And the function of the prostate is during ejaculation, it's responsible for maintaining the fluidity of the semen, as well as adding certain elements to the semen to enable ejaculation into the vagina. So the prostate's function here is highly dependent on male hormonal action. What this means is that the prostate is sensitive to male hormones like testosterone, specifically the more potent form of testosterone called dihydrotestosterone. So it has these receptors to dihydrotestosterone, which is about 40 times more potent than regular old testosterone. And what this is going to do is that when DHT binds to testosterone receptors, this causes prostate growth. Receptor. My bad. Sloppy handwriting. All right. Specifically, what ends up happening here is that the enlargement of the prostate leads to something called hypertrophy. Hypertrophy? Would it be a kind of, I guess hypertrophy is only in muscle. So I guess it would just be hyperplasia. And what is important to know about hyperplasia is we're talking about an increase in the number of prostate cells. So testosterone is coming along, binding to the receptors on the prostate, causing it to grow. Then all of a sudden, you have more prostate cells, which means that there's more testosterone receptors, which means that there's more growth happening on, which means that there's more cells and then more testosterone receptors. And so what ends up happening is you get this continual growth of the prostate, which in a lot of ways mimics what cancers do. The difference between BPH and prostate cancer is that BPH will not metastasize. And specifically, the reason why is that it has to do with the balance of these hormones. So let's dive into the pathophysiology a little bit more here. There we go. In males, let me change colors. Prostate growth is dependent on, firstly, direct testosterone stimulation. So if you have more testosterone hanging around, then you are going to cause the prostate to grow. The other major factor that ends up playing into this is an increase in estradiol stimulation if you guys, did you talk about estrogen biosynthesis and biochem? I can't remember if they talked through the steroids and all those kinds of different things. Maybe, kind of, maybe. No? All right. In the body, doop, 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 doop. In the body, the way that estrogen is produced is that you start with cholesterol, which is eventually turned into pregnenolone. Yes. Pregnenolone, which eventually becomes testosterone. I'm skipping a bunch of steps here, but this is what's important. Now, testosterone goes through two major changes. The first is that it can be metabolized into or synthesized into dihydrotestosterone, which, remember, is the more potent male hormone. So when you think about the action of testosterone, we care about DHT. The other place that testosterone becomes is estradiol. Also, if you're curious, progesterone comes out up here. What's important is that in males, the balance between estrogen and dihydrotestosterone is tightly controlled. Generally, we want a ratio that is much, much, much higher in DHT than in estradiol. So the ratio is much, much favored towards the testosterone levels. So here is how BPH can happen. Essentially, one of the biggest things that ends up happening is that DHT, testosterone, causes initial prostate growth, which over the course of a male's life is what enables the prostate to function. So we have normal prostate function. As the male ages, you have a greater imbalance of testosterone to estradiol, meaning that the amount of testosterone is going down while the amount of estradiol is staying the same. So the ratio here appears to be an increase in estradiol. This relative increase in estradiol leads to a major surge in prostate growth. Is this making sense so far? Kind of, sort of. But I thought, yeah. I both do. Both are able to increase the prostate. The problem is that DHT is able to balance the growth and not growth. Otherwise, over the course of a male just existing through their youth all the way up until they die, the prostate would get really, really big. But through specific mechanisms of the testosterone receptor, the androgen receptor, as the androgen receptor becomes more and more stimulated, the prostate starts to get rid of those receptors. So if you have this surge of testosterone, the prostate will actually reduce the amount of receptors to prevent overstimulation and overgrowth. what ends up happening is that as a male ages, because they have less testosterone and the amount of estradiol stays the same, you don't have this balancing effect between the two different hormones. So not only do you have testosterone stimulation causing growth, what little amount of testosterone is left, but then you also have estrogens causing growth that's not being balanced by the correct amount of testosterone. Does that kind of sort of make sense? Does anybody have questions about that? Would there be upregulation? Yes. And in fact, the upregulation causes both more testosterone receptors and estrogen receptors. So, yeah. So, which is why you get this runaway growth of prostate cells and causes all these different issues. All right. So we talked about how earlier that having this enlarged prostate is going to squeeze the urethra and make it really hard for someone to push out the urine, which is essentially the main symptom of BPH, is that you feel like you have a very, very big full bladder, but you're not able to empty it because your urethra is closed. It's swollen shut by the prostate. What this means is that we have to we treat BPH not only to reduce the prostate size, but also to affect the bladder's ability to let out urine. So let's take a look. In terms of treatment, the in terms of treatment, obviously we have those same non-pharm recommendations that we should always be making, right? Exercise, diet, all very, very important aspects of decreasing fluid intake is also another portion. Anything to stop this extra amount of pressure on the bladder. Specifically with non-pharm, decreasing the weight is very important in BPH. The reason is because fat cells produce estrogen. So someone who is obese and has a large number of fat cells is going to have more prostate hyperplasia, more prostate growth than someone of a smaller size. So not only do we want to decrease weight because that will put less pressure on the bladder, but it's also going to have this hormonal effect that's very, very important for decreasing the size of the prostate faster. There's also what are called bladder training techniques or bladder education. And the key characteristics of this is that you can have bladder retraining, which is almost like you're taking someone through the process of toilet training again. So you're telling them to resist the urge to void until they get to a certain point where they're going to be more successful in their urination. You can do something called double voiding, which is essentially where you can press on the bladder as you're peeing, rocking side to side, uh, 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 like listening to running water, anything that's going to help the urine flow, and facilitate completely emptying the bladder. And then the last part here is this technique, which I've had to educate a few patients on, called prostate milking. What prostate milking is that you, sorry, not prostate milking, urethral milking. My bad. Urethral milking is this technique where you are, after someone urinates, you grab the base of the penis to essentially prevent dribbling of urine until the sphincters close. So someone would hold the base of their penis for about 30 seconds to about a minute, and that would give the body enough time to close the sphincters and prevent any dribbling into the clothing. Dribbling is a funny word. I agree. In terms of drugs, in terms of management, really, drugs are actually first line and preferred over surgery. The reason is because it's very hard to remove the prostate because it wraps around the urethra. And if you cut through the urethra, you're going to have a really, really hard time getting it to suture back. The big issue is that if you cut through the urethra completely, the pressure of the urine will actually push apart a suture, and then you have urine spilling into the space inside the tissue. So essentially, you pee inside of your groin, which is not good. In terms of drugs, our first option about surgery, uh, essentially, is that surgery is not a good. It's not a great option for someone who has like a really, really large prostate because uh, there's the you might cut through the urethra, which would um, make it very, very, very hard for uh, you to essentially recover. You have to be in a catheter for a long time, I believe. Um, not good. Not good. Our first line drugs here are primarily going to be the alpha blockers. Specifically alpha 1. And the reason is because we're going to be focusing on um, relaxation of smooth muscle at the bladder neck and around the prostate. What this is going to end up doing is that it's going to reduce the resistance to outflow. Remember, in overflow incontinence, someone has a full bladder and they cannot get it out. They are full of pee and they're unable to release it. Because they are unable to release it, they have dribbling of urine, which is the incontinence part. In BPH, we have the same issue. They're unable to release the urine when they want to. And so what the outcome of treatment with alpha blockers is symptom control. So is using an alpha blocker an actual cure or for in the enlarged prostate? No. Tamsulosin, doxazosin, alfuzosin, terazosin, these drugs are only going to help in urinating. What this means is that these drugs are not preferred in very large prostates. Why would they not be preferred in very large prostates? What do we think? The size, definitely. The reason is because it's only helping with getting the urine out, but it's doing nothing about the actual issue, which is the prostate squeezing the urethra, right? It's not reducing the size of the urethra, of the prostate. So these drugs enable someone the ability to urinate. In BPH, people have a hard time urinating. They know they need to go, but they just can't do it. It's like if I told you right now, stand up and go to the bathroom. And then as soon as you go to the bathroom, I say, okay, now go again. You just can't do it. Same thing here is that anything that they try, no matter how hard they push, they can't get the urine out. So these drugs enable better symptom control. The next category of drugs are called the 5-alpha reductase inhibitors. These drugs, which are finasteride and dutasteride, these drugs work on the conversion of testosterone to its active form, dihydrotestosterone. So these drugs are coming in and blocking testosterone from being converted to its active form. What this results in is decreased levels of DHT, of active testosterone, which is going to decrease growth, right? Because we're rebalancing, or what ends up happening here is that because we have no testosterone stimulation, we're going to reduce the growth even with, they also go to, decreased growth and increased apoptosis. So not only do we stop the prostate from growing, but we actually shrink it. Could it cause necrosis? Maybe if you overdosed on it, but even though you are, what's important to note is that these are specifically working within the prostate. So, but you have like the testicles are producing testosterone and dumping that into the blood. So you still have a tiny amount of testosterone coming from a different area. The outcome here is that we decrease the prostate size and we have better symptom control. So not only are we treating the actual issue, but now we can make it easier for someone to control when they want to urinate. Five alpha reductase inhibitors have very significant side effects, though. Because of the reduced testosterone, you have a significant amount of sexual dysfunction. Decreased libido, penis, numbing, ejaculatory dysfunction. Sometimes it's permanent. The effect of finasteride specifically can result in permanent sexual dysfunction. It is a really, really, really terrible outcome of these drugs. Sometimes it can take years for the sexual dysfunction to go away. Most of the time, it does not. So for people who get the sexual dysfunction, which is not everyone, it can be fairly devastating because they are never able to come to completion ever again. Other aspects of having decreased testosterone are things like gynecomastia. By the way, if you're wondering, well, what does it really matter? Sexual, like we use these BPHs for like elderly males, like 80-year-olds. Finasteride is used in alopecia and male pattern baldness, which is where these drugs are getting used in younger males. So you have like a 22-year-old being put on finasteride and never being able to enjoy sexual stimulation ever again. And yeah, it really is terrible. And I feel for these people a lot. They and it's not a very well described condition, unfortunately enough. Another option, but not nearly as preferred, are the antimuscarinics, as we talked about before. So oxybutynin, trospium, darafenicin, solifenacin, all those good guys. And then the last group we have are the phosphodiesterase 5 inhibitors. The PDE5 inhibitors are specifically relaxing. Oh, put it down here. These guys relax the urethra and prostate smooth muscle. So very, very similar to what the alpha blockers are doing. Does anybody know which the drugs that are the PDE5s? Guarantee you guys have heard of this drug before. Tadalafil, which is Cialis. You might be thinking that do you know the other one? The other PDE5? Sildenafil. Yeah. Do you know the brand name for sildenafil? You got it. You know this. Viagra. Yeah, of course. The little blue pill. Only tadalafil is indicated for treatment of BPH. Sildenafil is not indicated. Could it be used? Yes, totally can be used. But does it uh is it FDA approved? No, it is not. Does not work. Obviously, the biggest side effect to tadalafil is an erection. So yeah, we're using it to help someone pee better. Imagine if they took you told someone this drug will make you pee better, and they take it, go to work, and now they have an erection for the rest of the day. Yep, it's also used for erectile dysfunction. Yeah, so sometimes a side effect is the reason why we use a drug. Sometimes it's not. Um, all that good stuff. Other things is it increases the strain on the heart. So someone who has like heart failure or angina, not a good candidate for tadalafil. All right, so we have a bunch of drugs here, but how do we know what to choose? And essentially, what this is driven by is um, the um, yes, Sarah. What do you mean by that? When we look at BPH, what we are essentially trying to do is treat someone's LUTs. LUTs is lower urinary tract symptoms. So just because someone has BPH doesn't mean that it's going to manifest the same way in everyone. And there are two different kinds of LUTs. We can have what are called irritative symptoms, which is really issues with storage of urine. And the way that you should think about this is almost as if it looks like someone has an overactive bowel. So they're have lots of urgency, lots of incontinence, lots of uh, frequency. So someone with irritative symptoms feels like, oh my God, I just got to go pee. Like, I'll be right back. I got to go pee. It can get so bad that they have nocturia. NOCT, nocturia, meaning that they pee while they're sleeping. So their body is causing this stimulation of peeing, meaning that, the body wakes you up while you're sleeping and says, all right, go to the bathroom, go to the bathroom, go to the bathroom. And the thing is that you're not passing any significant amount of urine. You're passing less than 20% of the amount of urine you actually have inside of you. So you're getting up 5 to 6 times a night, which is not good. The other kind of symptom that you can have is obstructive, which has to do with voiding of urine. And these are more indicative of almost like a urinary incontinence viewpoint. So overactive bowel, you're constantly going to the bathroom. Obstructive symptoms makes it look like you just can't do it. And we describe this as something like hesitancy. So if you've ever walked up to the toilet and you're just waiting to start peeing, and you're waiting, you're thinking like, come on, body, just like take over and start. That's hesitancy. You just cannot start peeing. The other thing that happens is that you strain because you can feel that you have a lot of urine inside of you and it's not coming out. So you push and you push and you push. Once it does start flowing, you just have tons of dribbling and weak streams. So instead of it coming out at a steady rate with enough pressure, it's just leaking out of you. And so you end up sitting on the toilet for 10 minutes, hoping that all of the urine is going to come out and not into your clothing. Probably the most frustrating is you have the physical sensation of incomplete voiding. Next time you go to the bathroom, start peeing and then stop halfway through, get up and walk away from the toilet. It's a very, very weird sensation because your body is telling you you're not done, and you have a lot of stimulation going on in the bladder and the prostate, or your sphincters. And that's what someone feels like constantly. They just know they have urine inside of them, but they cannot get it out. Awful, 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 awful. All right. So, how to choose which drug to use. If someone has obstructive symptoms, it's because their prostate is too large. The cause of obstructive symptoms is a prostate physically blocking the urethra, making it hard for the urine to come out. So what are the 2 different drugs that you could use for a prostate that's too large that we talked about earlier? 2 different classes. Kind of. We'll talk about tadalafil in just a second, but what else could we use? What are some drugs that primarily help with the size? Right. So for larger prostates, we're going to primarily use the 5-alpha reductase inhibitors. For smaller prostates, we can use the alpha-1 antagonists. For larger prostates, you can also use the alpha-1. So if using finasteride by itself doesn't work, throw in the combination therapy. Almost done. For irritative symptoms, this is all about the detrusor muscle. And so detrusor overactivity. And so what you're primarily going to be using is the 5-alpha reductase inhibitors plus the antimuscarinics. Right? These essentially looks like urge incontinence, so we're going to use drugs very similar to urge incontinence. Where tadalafil comes in is more so with obstructive symptoms. I'll put it this way. Obstructive with erectile dysfunction. This is where we're really going to be using tadalafil. The reason why we put this restriction on tadalafil is because it is the side effect of the erection can be really irritating for people. Now, unlike when we use Viagra or Cialis for actively having sex, the doses that we're using it for BPH are much lower. And essentially what it means is that the drug isn't going to cause an erection to happen, but it makes it much easier for one to start and much harder for it to go away. So what ends up happening is that someone might be, in the office, they become stimulated by something, and then all of a sudden they have a full erection that won't go away. So it can be very, very disturbing for people to try to manage that problem. Does that make sense? Any questions about that? All right. Please, 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 if there's one thing that you pay attention to, your LUTs. LUTs is a very, very, very important part of treating BPH. So on the exam, most of the questions about BPH and treatment are going to be about LUTs. That's what they're going to come to. All right. LUTs. All right, everyone. If you have any questions, let me know. Tomorrow we have tutoring, 7 to 9. I'm just about done coming up with cases for Thera. It's hard to come up with drug interactions one, and it's the other one you have. Can't even think of what it is. But different stuff like that. There's probably a med kit. Oh, yeah. It's hard to because you guys haven't learned a lot of the drugs yet. So I don't want to I have to go back and try to remember what that content was all about. But all right, cool. I will See you guys later.
Oh, just a quick question though.